Good evening. I'm Jeff Spence from the Office of Alumni Relations at Thomas Jefferson University. It's my pleasure to welcome you here tonight. This evening, we will examine the struggle many of us face in turning off the stresses of the day and finding a restful night's sleep. I know for some of us, this past year has certainly added to those sleepless nights. To lead our program, it is my pleasure to welcome Dr. Karl Doghramji. In addition to being a medical college graduate from the class of 1980, Dr. Doghramji is the medical director of the Jefferson Sleep Disorders Center and program director of the Fellowship in Sleep Medicine at Thomas Jefferson University Hospital. In addition, he is a professor of psychiatry, neurology, and medicine in the Sidney Kimmel Medical College. Welcome, Dr. Doghramji. You may begin when you're ready.
Thank you very much, Jeff. It's great to be here with all of you. Let me turn on my light and make it transform us from night to day. I wish I could see all of you in the audience. I cannot, but I wish you a welcome to those of you who have not been here for a while. And I certainly would like to thank all of you for joining me on an evening when I'm sure things are very busy for you. Let me turn to my share my screen with you so that I can bring up my slides. So the next 30 minutes or so, I'd like to explore this whole area of sleep, go over some of the thoughts that we have about why we sleep and how we sleep, and then delve a bit into some of the things that we can do to help ourselves sleep better, with the presumption that many of us do not. And finally end with some other strategies which we can utilize, or rather methods that we can utilize to seek additional help. First of all, in terms of Jefferson, many of you may not realize this, but there's been a long history of sleep medicine research at Jefferson. Dr. Eugene Nazarinsky, who was one of the discoverers of rapid eye movement sleep, was actually chair of physiology right here at Jefferson. Dr. Al Beal is one of the founding members of the whole area of dream research and was one of the faculty members in the Department of Psychiatry at Jefferson many years ago, in whose name there's a lectureship endowed within psychiatry. And our sleep laboratory was actually the first one to be located in Philadelphia, endowed by an NIH grant, as well as a grant by some alumni. So there's a lot been going on in sleep here at Jefferson for many, many years. Our Sleep Disorders Center is comprised of a number of beds which are dedicated to the study of sleep disturbances, and it's located in Center City. It's actually a state-of-the-art facility. And we have, in addition, 5 ambulatory sites where we actually see patients within the Center City and suburban areas. These are the physicians and clinicians who specialize in sleep medicine, at least in the Center City area. If we expand this in terms of the number of folks within the enterprise in general, Abington, Northeast, as well as New Jersey, that number is probably more like 40 or 50 physicians and nurse practitioners. We use a team collaborative model at Jefferson, where patients undergo a number of different evaluations in different disciplines, including sleep medicine. And this is fairly well coordinated in the care of patients to be able to understand what's going on from a sleep standpoint in multiple different disciplines and formulate a final diagnostic plan. So now let's talk a bit about sleep. Sleep, as many of you know, is something which we all need. We all obtain it. Even if we haven't got enough of it, the body finds a way to get it. Here's a child who's sleeping in an inopportune place. Here's a dolphin. Interestingly, dolphins who have to move around in order to solve a very important biological function. That is, they can't just stay still. They have to move around to breathe and so on. Dolphins have this interesting structure mechanism where half the brain sleeps while the other one is awake. And once one brain is done, they switch. Fascinating way of ensuring that the organism gets sufficient sleep. So sleep is important. What exactly it's important for has been an area of significant research. And at least one of the functions we know is to be able to rid the brain of toxic neurochemicals. These are a number of different ones exist, such as these beta amyloids, which are toxic to neurons. And why, though, this has to happen during a sleep state, and why cannot happen as much when the brain is awake, that's something which we do not quite understand. But we know that without sleep, important functions begin to deteriorate, and eventually animals lose weight and are unable to maintain an anabolic state and end up dying. So sleep is important to human beings as well as animals. In fact, every living organism we have out there known to man exemplifies some evidence of sleep, including plants, by the way. Now, we know that sleep in human beings is divided into distinct stages based on electroencephalographic characteristics. We all enter the doorway of sleep through stage. We all enter sleep, I should say, through the doorway of stage one, which is a shallow form of sleep where mental activity exists to some extent, but fleeting imagery in the form of fleeting imagery, as opposed to dreams. And then we finally enter stage two sleep within about an hour or so, and then finally enter slow wave sleep, and finally enter REM sleep or rapid eye movement sleep. This cycle of stage 1, 2, 3, 4, and REM is about 90 minutes in duration in human beings, and it recurs throughout the course of the night. You'll notice that rapid eye movement stages increase in length as the night approaches. During these stages, of course, we do most of our active dreaming. And the dreams intensify as the night approaches. The beginning of the night is dedicated to slow wave or delta sleep. Delta sleep is the deeper form of sleep, which we think we need to get a lot of in order to feel refreshed during the day, although there's some controversy about that statement. There are many different factors which affect this, what we call sleep architecture, negatively, and which then produce sleep symptoms. Age is one. Age is a very important one. Unfortunately, age is destructive of sleep, as we'll see in a couple of minutes. Menstrual cycle, pregnancy, and menopause in women. Sleep deprivation produces alterations as well. Environmental factors such as temperature extremes, noise, light, medications, disease states, and many, many others. And our job as sleep doctors is to be able to identify these factors and to treat them in order to improve sleep. Just an example of what happens as we age. As we age, slow wave sleep or non-REM delta sleep diminishes precipitously, so that there's very little left by the age of 60 or 70. In contrast, stage one sleep, a more shallow form of sleep, increases in proportion to the rest of the sleep stages. REM sleep diminishes as well, and we lie awake in bed more as we age. So the entire efficiency of sleep diminishes because we're actually lying in bed, but the amount of time we've slept during that period of time is actually less. And one of the reasons why we think the older individuals feel less refreshed and feel more sleepy during the day is that their slow wave sleep levels are less, and they dedicate less time actually physically sleeping in terms of the time they're spending in bed. Now, these symptoms that are caused by sleep architectural disruption are many, but the two most common are insomnia and daytime sleepiness. And insomnia is a very common problem. It's the second most commonly reported health complaint worldwide. And you can see that if you add up the proportion of folks who have said that they either have insomnia a few nights per week or have it every night, it's about 54% of the U.S. population, and this is over the course of a 2 or 3 week period. So that's quite a large number of individuals. If you also examine individuals who've had complaints of daytime sleepiness, feeling fatigued, lethargic, about 31% of the population. 29% of the population states that they have this problem almost every day or a few times per week. So these are very, very common problems. Sleep disorder symptoms are very, very common problems. Now, in the next 20 minutes or so, I'd like to talk about some of the behavioral reasons why we might have sleep disturbance and what we could do about these behavioral abnormalities in terms of restructuring our behavior to be able to accomplish better sleep. And then I'll talk a bit about the disorders that we can identify and treat. But let's talk about the behaviors. What can we do to improve our own sleep? And this is a quick summary. First of all, allowing adequate time for sleep, establishing a daily activity routine, waking up at the same time every day, increasing exposure to bright light during the day, decreasing light exposure in the evening, exercising regularly in the morning and the afternoon, setting aside a worry time, setting aside a time to worry, doing something relaxing prior to bedtime, and finally trying some temperature changes for the body. So let's talk a bit about just these techniques. First of all, allowing adequate times for sleep. What are the right times for sleep? Well, those vary across our lifespans. Certainly when we're born, 14, 17, 20 hours a day of sleep is not atypical or abnormal. Children tend to fragment their sleep into small little patches throughout the course of the day. which of course is very troublesome to their moms and dads, especially their moms. But ultimately, as we age, we develop a bimodal time for sleep, where we tend to sleep primarily at two times of the day. One is at nighttime, and there's a small mode, additional mode in the afternoon. That's what we call the siesta. So as we age and approach the age of possibly teenagers or young adults, 8 to 10 hours is really what we think individuals require. And finally, in adulthood, 7 to 9 hours is really the number of hours that are optimal to maintain alertness during the course of the day. Obviously, some people can get away with less sleep. Some people need more sleep, but the vast majority of individuals need this amount of sleep. Now, if they don't, they fall asleep. They tend to not be able to maintain wakefulness. What's also important is that these sleep decrements that can produce daytime sleepiness are not necessarily are additive in terms of their chronicity over time. So this is an experiment with normal individuals looking at the effects of a chronic sleep deprivation. So if you look at individuals in this red line here who have been totally sleep deprived for the entire night over the course of 2 nights, you'll notice that they begin to commit greater number of attentional lapses or errors as these 2 nights go along, so that the peak number of errors is about 16 after 2 days of complete sleep deprivation. Now, here are individuals in green who are being not deprived of sleep completely, but their sleep is being reduced to 4 hours per day. So not complete deprivation, but sleep reduction. You can see that the number of mistakes they make also increase, but they reach the same level as individuals completely sleep deprived for 2 nights, but they do so within 2 weeks, not within 2 days. The same thing for individuals whose sleep has been reduced by an incremental number of hours, who are getting only 6 hours per night. Even those individuals become sleepier and sleepier as time progresses, because the sleep decrements that they have per night are additive in nature. Even individuals who are getting 8 hours of sleep on the very bottom tend to have an increase in sleepiness, meaning that 8 hours may not even be enough for many individuals. So sleep decrements are cumulative in nature. And the other corollary to this is that to pay back sleep decrements and to become less sleepy during the day, one has to make up for sleep over long periods of time. So this is an example of sleep deprivation, chronic sleep deprivation. To assess whether or not you might have sleep deprivation or if you're sleepy or not, this is a good scale to use, the Epworth Sleepiness Scale. And basically you add up to your score of how likely you are to doze off in each of these settings. And if your score is above 10, you basically are a bit too sleepy. And you may want to import this from any website. It's available all over the place after the lecture, and add up your score, the Epworth Sleepiness Scale score. Now let's talk a little bit about not sleeping well and some of the strategies to help in that regard. Establishing a proper sleep timing and light exposure are probably the two most important principles. Establishing a daily activity routine. So getting out of bed at the same time every day and increasing exposure to bright light during the day. See, our bodies are used to this day-night cycle, but as we've evolved as human beings, we've begun to replace regular light with artificial light when the body normally doesn't obtain that, as in the evenings. And in the mornings, when we should be getting lots of light, we've actually replaced that with darkness or dim light in our office-based settings. So the light-darkness cycle that we need so much, which also influences our endogenous circadian rhythms or biological rhythms, is lacking. And that rhythmicity, therefore, is lost in an internal sense as well, producing complaints like insomnia and daytime sleepiness. Again, light coming into the brain through the retinohypothalamic tract eventually makes it to the suprachiasmatic nucleus, which results in the synthesis of melatonin. And melatonin is the signal that goes to the rest of the body and adjusts the rhythms of all of the body organs, things like the liver, the brain, the lungs, the gonads. All of these adhere to this sleep-wake rhythm. I apologize, to the light-darkness rhythm that is being orchestrated outside the body. And the way that they follow this rhythm is through the signal of melatonin. And the only way melatonin can produce that signaling system is to be able to be exposed to light and darkness at the right times. So the timing of the environment is translated to the rest of the body through melatonin and through the light stimulus that you expose yourself to. So bright light during the day, when you wake up, bright light as much as possible. If you can't get regular light, artificial light boxes are available, and I can talk to you about those as well if there's any question about those. And dim light as much as possible in the evening. Now, some people cannot do without cannot unfortunately follow this recommendation of dim light in the evening. We're exposed to television sets, to computers, to various smartphones, all of which have a spectra of light which are destructive for biological rhythms, and that spectrum is in the green to blue range. So there are glasses available which thankfully filter those specific wavelengths out. Blue light filter glasses, which are nice to use in the evening if you cannot do without your whatever device it is that you're using that emits light. And I would recommend starting to use these glasses 2 to 3 hours prior to your normal bedtime. um, these glasses are not medical grade in the sense that they've not been tested and approved for this type of use. But you can actually look these up, and there's a number of consumer reviews for each of the glasses available commercially to see how effective they are in filtering light from coming through them, filtering the blue light from coming through them into the eye. We use these techniques a lot for shift workers who are basically sleeping during the day and working at night. So we use artificial light boxes, as you can see here. We use these boxes when they're working during the course of the night to remain awake. So their bodies are fooled to thinking it's day. And then, of course, during the night when they're sleeping, I apologize, during the day when they're sleeping, the rooms are made to become as dark as possible. And on the way home, we have them wear these glasses which filter blue as well as other forms of light. Now, we know that exercise can also be very helpful for sleep quality and then also for sleep continuity. Exercise regularly performed, not within 4 hours of bedtime, but in the morning or afternoon can be very helpful. So regularity is important, as well as the timing of exercise is important as well. In addition, it is the aerobic form of exercise that seems to be most helpful. So that's another thing to think about in terms of sleep depth and continuity. The worries that we have can also be destructive of sleep. I'll talk a bit about the COVID pandemic and how that's introduced some worries into our lives. But many of these worries can be subtle in nature. They could be subliminal, unconscious, and not really things that we think about every day at any particular time during the day. But some of these worries could also be full-blown anxiety and full-blown worries, which produce anxiety and panic attacks and so on. But so the way in which we get rid of these worries normally is to be able to synthesize them cognitively and be able to think about them and to be able to put them into context, or to be able to throw some logic at them and be able to get rid of them in that fashion. But many of us don't have the habit of doing so on a regular basis. So I would recommend, for those of us who are not in therapy, who are not going through these analyses on a regular basis, is really set aside a time when you can think about your worries, think about your concerns. I usually recommend something prior to dinner, around dinner, but not too close to bedtime. Half an hour or so, just sitting around and not really doing too much else with that half hour. No television, no book reading, just sort of thinking to yourself, thinking about things that you come to mind. And believe me, if you allow yourself that half hour, things that will come to mind will be the things that you were worried about. But to be able to think about them, address them cognitively is very important, because if you don't do them at that time, they will be haunting you when you go to bed, and that's what we're trying to prevent. The relaxing activities prior to bedtime, and there are many different kinds: yoga, meditation, maybe reading a book that's not too activating, of course, with the glasses, with the blue light filter glasses. But the converse is that many medical students and residents, doctors, people in challenging professions, and so on and so forth, will do all of their reading and do it very close to bedtime, and that tends to produce sort of this sense of being a little bit more concerned or anxious as bedtime approaches. Again, body temperature changes. Most people prefer a bit more warmth just before bedtime or around the time of bed to be able to relax. And there seems to be some physiologic basis for the production of better sleep by warming oneself. But interestingly, after you go to bed, it's better for the room to be on the cooler side. And I'll get to that in a couple of minutes, but a warm bath or something that warms the core body temperature could be helpful. Some common sense things such as a dark bedroom, minimizing noise. There may be some noises in the environment, like street noises, which could be affecting you. These earplugs or ear noise preventing types of devices may be helpful, and the bed should be comfortable. There's no real type of bed that's best for everybody. It's stiff, soft. It's whatever makes you feel most comfortable. As I said before, lowering the temperature in your bedroom can be helpful. Once you've gone to bed, you have your covers on, make the room a bit cooler than what you would normally make it during the course of the day. Cool bedroom surroundings seem to be more helpful for sleep. Now, one of the things we should not do in order to not make sleep worse, well, avoiding alcohol, substances which can be destructive of sleep, like caffeine and nicotine, heavy meals, using the bed for things that are not necessarily sleep related, and I'll talk that in a couple of minutes, watching the clock, staying in bed for too long of a period of time. There's such a thing as spending too much time in bed and too much napping. First of all, substances. We know that heavy meals tend to be disruptive of sleep because they produce reflux, and reflux can be destructive of sleep even if you don't feel acid burning in your stomach. Smoking, obviously, caffeine. Some people don't metabolize caffeine that quickly, and in general, caffeinated beverages should be avoided after lunchtime. After lunch, no Red Bull, Starbucks, or Pepsi after lunchtime. Avoiding things in bed that are not necessarily sleep related. People, do all sorts of homework, classroom work, telephone, iPhone, whatever in bed. Bed should be really dedicated to sleep and intimacy only, because once you do too much else in bed, the bedtime and bedroom becomes psychologically associated with these other things. And there's an awakening response. So it's that Pavlovian conditioning coming into play. And not watching the clock. When you go to bed, take all cues out of your reach. So only look at the clock when you wake up in the morning and the alarm rings. But between bedtime and morning, don't worry about that clock, because the more you watch it, the more those obsessional mechanisms come into play, and you begin to worry more about it. If you stay in bed too long and cannot sleep, get up out of bed. And how long is too long? Well, about 30 minutes, maybe 45 minutes for some people. But if you can't sleep in 30 minutes, the more you lie in bed, the more problematic it becomes, because the worry cycle begins to set in. So get up out of bed, do something else, relaxing in a dimly lit room, and then come back to bed when you feel sleepy, and then do it again and again as many times as you need to during the course of the night. Now, these common self-help measures may not be helpful for everybody, and that's where we come in as sleep docs. And seeing patients who are disturbed by their sleep for long periods of time, where these measures have not been helpful, allows us to diagnose other disturbances which may exist, such as the ones on this slide. Of course, we do a fairly comprehensive workup to do that. I just want to say a couple of things about COVID and sleep. COVID has really interestingly intensified sleep disturbances in many individuals, and I see this in my patients all the time. And I think there are many factors, if we try to boil them down to specific factors, that might be causing this. First of all, we spend more time at home as opposed to going into the office, and that lack of a transition from home to office and back seems to have disrupted some of the rhythms or some of the rhythms, because of the lack of the typical zeitgebers or signal givers or rhythm setters that we typically have during the day to set our sleep-wake rhythms. Going to the office, coming back, and also the lack of a change in the environment has produced a sense of sameness, which has been somewhat problematic for people psychologically. Lives when they're sedentary, when there's less physical activity, as I mentioned before, physical activity is helpful for sleep, and the lack of it tends to be sleep disruptive. And I think that's the second factor which has been problematic with the COVID pandemic. And the third factor has been less exposure to environmental light, indoor settings, less light. The average American, even before COVID, gets only about half an hour of exposure to sunlight. And now with COVID, I can't even imagine how many minutes we are exposed to sunlight. As an example, today, I myself personally started working at 6:30 and 6 in the morning when it was dark outside. And I, besides dinner, I've been at this very desk that entire time working. So I'm a good example of some of the problems that people are having behaviorally, which have contributed to their sleep disturbance. Using their personal spaces for work and for sleep. So the bedroom in some small houses, some small apartments, or some small dwellings has also also serves as the workplace for some people because it also contains their desk and so on. But people don't really work there normally. But with COVID, they've been forced to work at their desks, which are located at the bedside, and that's eliminated the sanctity of this division between bed surroundings, sleep surroundings, and non-sleep or work surroundings, which is so psychologically important for the sense of being able to check out from work and then checking into sleep. And this, of course, social isolation. We're all social animals, and unfortunately, this social isolation has created heightened levels of anxiety and dysphoria, which has been not helpful for sleep. I worry about a number of things: economic future, personal safety, family safety, and grief and loss. As people have lost loved ones, unfortunately, because of this pandemic. And as a result, people have been telling me it takes them longer to fall asleep. They wake up multiple times. Sleep is unrefreshing. They sleep later into the day because when they get up in the morning, there's no need to get up at 6 and commute to work, so they get up at any time. So that sacred awakening, morning awakening time has been lost, and disrupting circadian rhythmicity. The mind is overly active when people go to bed. They've been having disturbing dreams and nightmares. I see people having lots of recurring dreams and nightmares that are distress filled with distressing topics and distressing content, and of course moodiness and feeling somewhat depressed during the day. Here's an example of the division between bedroom and the rest of the house that I like to let my patients know. Get a cheap curtain and put it in front of your bed so it looks like it's not next to your desk, not in the rest of your house, so that when you go to bed, you can check out into your bedroom behind that curtain. Many of our patients also need more formal therapies, such as cognitive behavioral therapy or CBT, talk therapies. We also use these therapies as a way of reducing tension and anxiety levels by doing things like biofeedback, relaxation training, which I'd be happy to talk about if you'd like. Jefferson has a number of mental health resources on My Jeff Hub. Those of you part of the Jefferson community know that this is a very important mental health resource, and psychiatrists, psychologists are available, as well as group therapy sessions for people who are having lots of distress and anxiety. It's not just centered around COVID, but just in general. In terms of medications, people take all sorts of things for sleep, and here's an example of some of the ones that people take: alcohol, herbals, melatonin, dietary supplements, over-the-counter aids, and so on and so forth, many of which are unfortunately not all that helpful, especially things like alcohol. If we see patients who are having sleep disturbances, tend to use some of the prescription medications, and there are a number of them which are fairly safe. This old notion that sleep medications are always addictive and cause problems, that notion is not necessarily true anymore with all medications. We can also identify other syndromes which can cause insomnia, like restless leg syndrome, and treat that with medications as needed. We can identify things like sleep apnea, which is a disorder where breathing is impaired because the upper airway closes, and we can treat that with a number of different ways as well, such as oral appliance, positive airway pressure devices, surgical techniques, oral appliances, body positioning appliances, and so on and so forth. Newest introduction in this category has been something called Inspire, or upper airway stimulation therapy. Just to give you a sense that not all sleep disturbances disappear, unfortunately, with these self-help measures. And for those of us in whom these self-help measures don't work, there may be something going on behind the surface, under the surface, that may need further investigation. Finally, those of you who are interested in exploring this topic in a more scientific manner, we have our 7th annual Sleep Medicine Symposium on March the 29th, just in a couple of months. It's a virtual format. You can sign up for this at the Jefferson Department of Continuing Education. And the CME website is cme.jefferson.edu. There's a discount for all of us who are a member of the Jefferson community. I'd like to thank you for your attention. And at this point, I'm going to stop my share screen and I'll turn things to Jeff, and then he will then take it from here.
Yes, thank you so much, Doctor. We do invite our guests to use the Q&A button located at the bottom of your screen to ask any questions you have for Dr. Doghramji. We will take questions as long as time allows, and we did receive quite a number of questions in advance, so we'll get started with some of those. So, Doctor, we did receive a number of questions that warrant maybe diving a little deeper into sleep medication. Specifically, we have a number of questions around Ambien.
Mhm.
Wondering, one, whether you find it to be a safe medication, two, whether or not dependency becomes something to be concerned about.
Right. Yes, Ambien is one of the more recent, what we call Z drugs, or the drugs which are not like the older benzodiazepines, but newer selective benzodiazepine receptors. Ambien is a drug which is effective. There's another version called Ambien CR, which lasts a little longer into the night, so it's a little bit better for patients, people who wake up a lot after they fall asleep, have nighttime awakenings, whereas regular Ambien is best for the beginning of the night, people who have problems falling asleep. It's a drug which can have side effects. If taken at higher doses, it can produce some daytime sleepiness. Ambien has also been associated with amnestic behaviors, people getting up out of bed, walking, doing things which they didn't realize they did. But that's especially true if people drink alcohol or take other sedatives with Ambien. Ambien can also cause some daytime impairment if it lasts too long in one's body. Memory decrement, for example, not remembering things as well, or maybe even in the older individuals who are vulnerable individuals, it may cause motor imbalance. So people get up out of bed, they feel wobbly, and they can fall. For these reasons, these are not reasons to not use Ambien. They're more reasons to use Ambien more carefully. So it has to be used more cautiously. It's a bit trickier to use than some of the newer medications. So I would say Ambien is a good drug. It has its place in clinical medicine, but it has to be used more carefully at low as possible a dose. Regarding tolerance and addiction, if used over long periods of time, the data show that Ambien can be used that way for most individuals without having them getting used to it, without having the insomnia get worse, without getting addicted. But people have a history of addictive disorders, alcohol abuse, drug abuse, probably should not take Ambien because that can increase those tendencies. Number two, some people begin to develop tolerance. So if they're taking the same dose, insomnia returns and they begin to escalate the dose. Once that occurs, that dose escalation occurs, I would recommend backing off on Ambien and even discontinuing it, because those are the folks who then can climb up that ladder and maybe reach too high of a dose. And there is where those problems begin to emerge. Hopefully that helps answer that question.
Yes, I hope so. Just a quick aside on Ambien. We've had a question about age and use of Ambien. Do you have any concerns in a healthy patient who might be over 65 beginning an Ambien treatment?
It's a bit trickier. The American Academy of Family Medicine and the American Geriatric Association have actually come down and said people above 65 should not use Ambien. Unfortunately, I think it's a real clinical world. Some people need the Ambien or the other sleeping pills. I my practice is to use Ambien for people above the age of 60 and 65 after doing a very careful evaluation and also using a very low dose. So as an example, instead of using 10 milligrams, I would use 5 milligrams or even 2.5 milligrams. And my experience has been that it's a very effective and extremely safe medication if I check with patients regularly and use it at those low doses.
Excellent.
Yeah.
And on more of a natural front, melatonin, we have a number of questions about melatonin. One is your view on the effectiveness of it. Can patients develop a tolerance that maybe inhibits their own hormone release with melatonin? And do you have any recommended doses for, or is that really situational?
Right. So melatonin is a hormone, naturally occurring hormone in the body, as I mentioned before. When we take melatonin, we increase levels of that hormone multiple fold in the body. So we're basically doing a super melatonin levels in our own bodies. Because melatonin is a hormone, it has its own receptors within our body. Every single body organ has a melatonin receptor, the brain, the liver, the gonads, as I mentioned before. So when we increase levels of melatonin in the body, we're super saturating every receptor with melatonin. Now, it, in addition to doing that, there are sleep receptors as well for melatonin. And by hitting those, we fall asleep sometimes. It does the job in some cases. But the problem is that by hitting all these other receptors, there may be some side effects for melatonin. And experiments have shown that it impairs some spermatogenesis in rats and laboratory animals. It can produce changes in the sensitivity of the receptors to certain chemotherapeutic agents. It can increase the amount of decrease the amount of insulin in the body and increase resistance to insulin and increase glucose levels in the body and on and on. So the important thing is by sleeping better, it doesn't mean that with melatonin does not mean that it's a very safe medication and just because it's available without a prescription. So I would say that melatonin can work. It doesn't work for everybody. The studies have shown that if it does work, it's very modest in its effect. It improves the amount of time we sleep by only on the order of 5 minutes or so, not much more. But if you're taking it and it's working, I would say take it for short periods of time, a few weeks, maybe a month or so, not much longer, and take it at this very small dose of 2 or 3 milligrams, no more than that. The third thing I would suggest is look into the better preparations of melatonin. It's not an FDA approved medication, so there's no real good studies on it. We don't know what the right brand is. So I'm not. I don't throw out brands in these types of talks, but the one that I've actually seen with some data is something called REMFresh, REMFRESH, and I have no relationship with that company, but I throw it out because I've seen some of the data in its purity, and it seems to be at least positive in that regard. So, but again, it's not a panacea drug, and it can have some side effects. Yeah.
Thank you for that. A handful of questions that we received are also about frequency of waking up throughout the night, and really looking at what kind of recommendations you may have to return to sleep as quickly and as calmly as possible. Um, any thoughts?
Yeah. So people wake up and can't get back to sleep. One of the things in the younger age groups is that when we wake up and we sort of lie in bed, the brain starts to churn, right? Especially as you wake up later into the night, your sleep debt has been paid off a little bit, so you're not as sleepy, believe it or not. When you go to bed at 11 o'clock, you're very sleepy. There's this pressure for sleep, so it's easier to fall asleep. But 2 or 3 or 4 in the morning, you've paid off a lot of that pressure. And now when you wake up, it's harder to fall back to sleep because you're not as sleepy. And in addition, of course, the mind begins to become worried. I would say two things. Number one, if you spend more than 20 minutes doing that, get up out of bed, do something else. Don't worry about not falling asleep for that night. And then come back to bed after about half an hour or so once you feel sleepy. Number two, learn some techniques of meditation and mental relaxation. There are a number of them available on the web. For example, listening to these beach sounds or ocean sounds, which can calm the mind down a little bit. So the idea is to calm the mind down from its sort of rapid spinning and rapid thinking kind of attitude. Number three, keep the bedroom, dimly lit as much as possible when you do that. So those are the three things I would recommend for people who wake up a lot during the night.
And then for a normal healthy adult, do you find that a siesta, an afternoon nap, is a healthy behavior, or when is it maybe harmful?
Yeah. No, it can be very helpful. As I said before, human beings have a bimodal distribution to their levels of sleepiness. We tend to be maximally sleepy at night and in the afternoon, 12 hours, after we wake up. And yeah, I guess uh, about 1 or 2 or 3 in the afternoon. So many cultures take the advantage of that and take a brief nap at that time. So I would say yes, a nap is not a bad idea for many of us. It can make us feel rejuvenated, alert afterwards. Sleep deprived individuals do this routinely. But the trick is this: try to make sure your nap is limited in length. So if you nap for anything more than half an hour, then your body's rhythms tend to become thrown off, and you may take too much sleep out of the nighttime, sleep pressure. So and not sleep as well at night. So I would say half an hour siesta, great idea.
Wonderful. That's wonderful. So we have a few questions too about dreams, vivid dreaming, nightmares, people who struggle with those disturbing their sleep. Um, some of our attendees tonight mentioned maybe even having sort of a fight or flight state when they wake up, feeling heart palpitations. Is there something that can, other than normal techniques, that maybe could help to identify those issues or calm them?
Yeah. So when we reach the realm of these sudden awakenings with heart palpitations, anxiety, disturbing dreams, I think we're beginning to reach the realm of anxiety disturbances, right? Anxiety disorders. Sometimes these are in the realm of post-traumatic stress. Sometimes panic attacks. Panic attacks sometimes occur during sleep and not during the day, and these are their hallmark symptoms: sudden awakenings, sweating, heart palpitations, an anxious mind, disturbing dreams just beforehand. These are good reasons to seek the help of people who specialize in treating these sorts of anxiety disorders. And the news is really very positive. Therapy, the specifically directed therapies for these types of disorders, those therapies are extraordinarily effective. Anxiety disorders clinics, there are many of them in the Philadelphia area, can be very, very helpful in helping diminish and getting rid of those. Medications, of course, can be helpful too. I mean, there are many medicines that could get rid of these, but therapy is really the first way to go. And I can talk about the specific therapies, but I don't think that would be necessary for this stage of our discussion. Yeah.
Thank you. What about people who feel that they have some dependencies on certain behaviors for sleep, whether it be TV, whether it be having somebody in the room or in the bed? Um, are they mostly psychological? Do they have bearing on really the physiological?
Yeah. So I lost you there, Jeff. Did you say people have a need for somebody be in the room with them? Is
So
that what you
either,
said?
yeah, so certain dependencies, it may be they feel they need to have the TV on in order to sleep. They need to have a partner or someone in the room with them.
Yeah, yeah. So I mean, in terms of the TV, at least, many of us do that. Television, computers, whatever. And the, what happens is that the day fills our minds with all sorts of troubles and anxieties and concerns and challenges. And and as I said before, many of us do not have the time during the course of a regular day to process these anxieties properly and to get rid of them. So we turn the lights off, we go to bed, and they're still there. They're still in our minds. They're still bothering us. So television is a good way of taking our minds off of these anxieties and concerns and sort of redirecting them to something benign and something not as challenging. So I do think that television serves a useful purpose. The reason why it can be destructive is the light that comes from TV. And for that, I recommend the use of those blue light glasses. So yeah, people need television or something to distract them. That's not such a bad thing. Radio could be another one. A radio is better in a sense because it doesn't have the light aspect. What about other people being there with them? Well, we start off in life by doing that, right? Our moms and dads are there with us when we go to bed. They're reading bedtime stories, taking our minds off of things and into the books of dreamland. But so that's not so bad either. It becomes a problem when you can't get to sleep unless you have somebody there all the time. When that person's not available anymore, right? Mom and dad can't be there all the time. So if you can't get rid of that person from your life and you need that person all the time, then that becomes a bit of a problem. Needing a TV every night isn't a big problem, but needing a person all the time, that's a problem unless that person wants to dedicate their lives to doing that. So there's where I think therapy could be helpful in sort of getting to the bottom of why is there that need? How can I divorce myself from that need? Yeah.
Understandable. We have a few folks who've shared a question and want to know your advice. If your lifestyle may not permit you to get a full 7 to 8 hours of sleep as an adult, whether it's work related, family related, where are other ways you can really maybe make up that energy or find ways to make sure that you're having sustained quality sleep there in a short period of time?
Well, I mean, if you know, that's the whole idea of sleep deprivation. How do you make up for sleep deprivation? The problem is you really cannot. If you really only get 4 or 5 hours of sleep per night, there's a deficit of 3 hours which will stay with you and which will build up the next day and the next day. And even if you don't, if you're not flat out falling asleep on your face during the day, by sleep deprivation after a few months of doing it, your brain will not be working as efficiently and your mind will not be as active. You'll be making more mistakes. You'll if you're an airline pilot, you'll be making more mistakes. We've seen that surgeons make more mistakes, residents make more mistakes reading the EKGs when they're sleep deprived. So you really must get that sleep. There's no ifs, ands, or buts about it. It's like asking me how many can I do without so many calories and still maintain my body, working correctly. Well, you can't. You need the energy in your body to be able to have your heart function properly. So it's not possible. So I would say find a way to make up that sleep at another time. If you can't get it at night, maybe get it in the afternoon. Maybe make your nap a little longer. Shift workers, people getting 5 hours of sleep per night, can make up for that 5 hours by napping for an hour to 2 hours in the afternoon at the same time every afternoon. Some people are lucky that they can make up for that lost sleep on the weekends. So they sleep 5 hours per night, and then on the weekend they sleep 12 hours per day, something like that. Now, some people can't get away with that because if they sleep 12 hours per day on the weekends, then their biological rhythms are disrupted. They go to work and on Monday, and their sleep is disrupted because their bodies are still on weekend time. So if you're lucky, if you can make up for your lost sleep during the week by 12 hours of sleep a weekend, go for it. But you have to get that sleep. You just can't do without it.
That certainly makes a lot of sense. And I think um, one of the other questions that I think that we are seeing a theme here is really, when do you know when you may need some medical intervention in sleep? How can you? What are some of the signs of apnea or other sleep disorders that really should seek some medical attention?
Yeah. I mean, if you've kind of done some of the things we've suggested, the behavioral things, and they have not helped, maybe that's a good reason to seek medical help. In terms of sleep apnea, it has some hallmark symptoms. For example, people who are sleepy during the day or wake up from their sleep at night and feel so sleepy, so lethargic in the morning. Even if they've gotten 8 hours of sleep, they wake up and they feel like their brains are still kind of fast asleep and they can't wake up and feel lethargic and during the day. And number two, if somebody said that they snore loudly, they have these breathing stoppages at night or gasps or gags in their sleep, those are certainly good signs that they may have sleep apnea. Apnea is also more common in people who tend to be on the overweight side or have thick necks, but those are not necessary for the suspicion of sleep apnea. Restless leg syndrome is another thing where insomnia could occur. These are people whose legs and sometimes their arms become very energetic when they go to bed, and they have to move around their legs and keep them in motion to be able to settle them down. So and those folks always have insomnia because they can't go to sleep because of the leg issue. So those are people that may need to seek additional help. I would say also people have brittle medical conditions and have sleep disturbances, may need to seek the help of a doc to be able to diagnose things like sleep apnea, which could be disrupting their medical conditions. So those are the areas I would seek help.
Thank you. I think we have time for just one more question, and it circles back to the concept of medication. For our attendees who are clinicians or involved in clinical care, who are working with patients who may have somewhat of a dependency on benzos, on other um, sleep aids, do you have any recommendations for techniques to wean their patients off?
Right. I should also mention that there are a couple of medications which are sleep medications, which are not benzos and not addicting. One of them is Ramelteon, whose trade name is Rosarum. It's a melatonin receptor agonist. And the other is called Silanor, which is actually doxepin, low dose doxepin, which is a tricyclic antidepressant, which has been reformulated at a very low dose just for insomnia. Those are non-addictive medications. In addition, gabapentin has been used as a sleep medication in patients with complex medical disturbances, and that's also non-addictive. But there are also some antidepressants such as trazodone, which is not a great drug, but is also often used for sleep, as well as uh, mirtazapine. So there are non-addictive choices for medications. But yeah, if a person's been addicted to a sleep medication, then the way to take them off of that would be a very slow reduction on an incremental basis. So let's say the patient's on, let's pretend 20 milligrams of Ambien, then reducing to 15 milligrams for a week, another 10 milligrams a second week, 15 milligrams, and reducing by 5 milligrams per week or even 2 milligrams per week, very slowly over the course of time would be the way to do it. And secondly, engaging at the same time in cognitive behavioral therapy for insomnia. That combination is very effective in getting rid of the medication that's addictive in nature.
Excellent. Well, thank you so much, Dr. Doghramji. We hopefully all will sleep a little bit better tonight as a result of today's presentation. And for those of you who have joined us, we want to thank you so much. I know that there were many questions, and some really have to do with individual patient care, and we would recommend that you consult. Feel free to contact the Jefferson Sleep Disorders Center or work with your primary care physician to determine your best course of care for some of your sleep issues. We do invite you all, though, to stay connected with Jefferson and with your fellow alumni by joining our brand new Jefferson Alumni Network at alumninetwork.jefferson.edu. And if you sign up before Valentine's Day on February 14th, you'll be entered into our weekly prize drawings. We also have a number of upcoming events that are both fun and informative, and you can find them at jefferson.edu/alumni events. Tomorrow evening, we'll be joined by the new fashion program director, Farai Samoy, who will discuss the impact of the COVID pandemic on the fashion industry. In the beginning of February, we will have a panel of alumni who have worked to convert their businesses in various ways to also address the need for PPE as a result of the COVID pandemic. And then we invite all of our alumni to join us on February 9th for our first ever wine and design night. And we do ask that you RSVP by Sunday so that we can send out your paints, your supplies, your canvases, and you just bring the wine. So again, visit jefferson.edu/alumni events for these events and others. Thank you again, and we hope you all have a restful sleep.